Okay, welcome, Dr. Vora.
Thank you, Angela. Good afternoon, everyone. It's great to see so many familiar faces. I hope you're doing well on a cold but sunny Friday. But at least we don't have new snow coming down. We do have new vaccines coming through, which is great news. So I'll just start out by saying that the pandemic that we are seeing right now, it is truly a once in a lifetime event for most of us, hopefully, except for one patient that I'll never forget. This was about 7 years ago, and I took care of her in a hospital setting. At that time, she was 97 years old, and she told me stories about the 1918 great influenza pandemic that she remembered vividly, and how there were so many deaths on the neighborhoods of Norwich, and how the funeral homes were so inundated. She had vivid graphic details that she could recall, even though she was a small child at the time growing up. The reason I bring it up is the scale of this pandemic and the death due to pandemic could have been as bad as the 1918 influenza if we did not have the access to the new communication, modern way of spreading awareness around the non-pharmaceutical intervention. Certainly, the availability of vaccine is going to change the course as well. And medical care has improved in the last 100 years, as you would hope as well. So even though the mortality due to the COVID pandemic is unacceptably high, it is not to the same scale as what the 1918 influenza pandemic did, where it is thought to have caused almost 50 million deaths worldwide. We're not done with COVID yet, or maybe the COVID is not done with us yet, but I'm hoping that the mortality on a global level will not be to the same level as we saw with the 1918 pandemic. Having said that, there are going to be downstream consequences due to the COVID virus, and it has changed the way we work, the way we live, the way we study, and the way we socialize right now. And this is a chance for us to also reflect and then reimagine what might that future look like for us as individuals, as families, as a community, as businesses as well. What are those changes that are here to stay, that are worth keeping? And what are some of those things that we really desire and cherish so much that we hope to get back to once we get back to a better normal? So I'll just pause there and see if we want to start off with any questions. To keep it more, conversational.
I can kick it off if you'd like. As far as through the chamber, we're a resource, obviously, that we're trying to connect and try to make sure that people all the information is getting to the right people at the right time. And obviously, it's very hard to get some of the information to our senior community right now. So that's been a challenge. Trying to be able to. A lot of them aren't. They don't know how to use a computer. They don't know how to call in. So there's been a lot of local resources that have been out there to help people. But is there any recommendations that you can give in order to help with some of the people to help the seniors to get the information to them in order to register? Can you register them yourself, or what are the challenges that you're seeing as far as that goes?
That is certainly a challenge. Surprisingly, many seniors are technology savvy. So we cannot just broad stroke the whole age group into that bucket. But having said that, there's certainly issues with access to, internet connectivity for many folks, access to computer or a mobile phone that can allow for looking up centers and booking and then keeping persistent focus because the opening may not be available at that time. So you almost need like an advocate, someone from the family or friends or colleagues or other social agencies that can provide that support to our seniors who are perhaps homebound or they may not have access to technology. So what we have done, what we have found is that having a coordinated clinic, a strike team clinic that goes out to where the seniors are congregating makes it that much easier, so that we don't necessarily have to have them individually log in to book an appointment. So there is certainly a possibility to collaborate along those lines through our partnership with the Eastern Connecticut Health Collaborative that includes Uncas Health District, Patrick McCormick, and Sue Dubbs and Jen Ciccarelli and the whole team. They're fantastic. But that's the type of intervention where if we know that there are 50 seniors who are willing, ready, and able to get vaccine, they're 75 and over, and they will be able to get together at town hall in a local town or nearby where the senior center is, pre-registering them into the VAMs and having a strike team come out to them would perhaps be type of approach that can help scale this vaccination fast for those that cannot really log in. Other options to consider would be to have kiosks at community-based organizations where, say, for example, a senior person comes to shop, and how maybe start looking at our businesses as also a digital doorway for our customers that generally would not have access to getting something done. Yes, it is not in our own wheelhouse. If I'm owning a yoga studio, I'm not really, necessarily in a healthcare coordination mode of a mindset, but these are unusual, extraordinary times. And I think we'll have to think together creatively around how maybe improve access to the available vaccines and connect people who need it with the vaccine in a prompt manner. So I'm open to learning what the folks on this call think. What are some of the other ideas that you may have come across?
So, Dr. Vora, this is Edie. Hi, everyone. So I'm on the strike team at Uncas Health, and I've been to 3 of their clinics now so far, vaccinating. First, we vaccinated phase 1A, was able to finish up our healthcare providers and our first responders. And all day yesterday and last week, vaccinating 75 and older. And just some of the strategies that you described, they're starting to implement as we learn along the way. So for example, the first clinic that I went to where we were vaccinating the 75-year-olds, we were explaining to them how they could make their second appointment. But yesterday we were actually making their appointment for them. So to make sure that they got back within the time frame and that they already had a spot reserved and a guaranteed vaccine. I love the ideas that you bring as far as, because everybody had an advocate with them pretty much. Everybody had a son, a daughter, a family member who either drove them or helped them get organized there. But I think the key will be, and I heard you say in the beginning, more vaccine is coming. I think that's what we're waiting for, because we have like kind of this finite amount of vaccine right now that we kind of have to strategize to make sure that at the end of the clinic day, we're not throwing any of it away. It does have a certain shelf life, people probably already know. So we want to make sure that the 100 vaccines we take with us that we give them all, and that we're not tossing any of them. So I think the logistics of getting folks signed up and then the matching of the number of vaccines with those folks is critical. So I love the idea of going to where the people are to sign them up.
This is Pam from UCFS Healthcare. I agree, UCFS is starting to do that too. So, you know, I think one of the problems is that it's not heavily communicated in marketing that where you get your first dose is where you should go back to your second dose. People are searching in the VAM system to try to get anything. So, you know, we identified that's definitely an issue. So before you leave UCFS, after you get your first dose, you have your second dose appointment. And we have a lot of people walking up without appointments just saying, I'm here for my second dose. No, go back to where you got your first dose. We're allocated the second dose based on the people we give first dose. So really what we need to stress to people is once you get an appointment for your first dose, you're golden. Don't stress out over the second dose. And hopefully more vaccination places will give them an appointment right away, because now you have people going on the VAM system, searching anywhere they can for their next open appointment for their second appointment. And it's kind of muttering up the system, and that some people aren't canceling them. So then there's a spot that could have been used for somebody else. So I'm hoping that the state will start stressing, go back to where you got your first dose, if at all possible. I understand sometimes it's not possible. But again, and I agree, the biggest thing is there's not enough vaccine for the people who want them. And that's out of all of our control, and unfortunately. But kudos to everybody that's involved. It's a huge undertaking, and it's awesome to be able to give the vaccine. And I was fortunate enough to get my second dose on Wednesday, and hopefully more and more people will be getting their second dose, and we can get rid of this thing or go back to normal life at all possible. So thank you.
No, thank you, Pam. That actually, Dr. Vora, that's actually one of the questions that came up this morning and concerns this morning, which Pam was just discussing. I had suggested somehow or another getting some flyers or getting some information, and we can help to get that information out there. And so Pam, have you come across anything that we can help to share amongst our, this committee and other members in the community to try to share that message anyway? Let us know, because that is tough. Speaking of second doses, that was my other question that I had for you. Is I'm noticing that some people, now that you're not supposed to take an aspirin or Motrin before or after because it could affect the vaccine. I'm hearing that. So if you could help to clarify that, but also that people are having more pain or fever or associated with the second vaccine. And I don't know if it's because they're not supposed to take Motrin or Tylenol, or if it's just, are you seeing that? Is that any concern? So maybe we can discuss that second round, because that's what I'm seeing more just this week, because people are now up in that 3 weeks later stage.
Sure, Angie. As most of the folks on this call know, the first dose is the priming dose, where the first vaccine delivers the messenger RNA for the spike protein, and the body's immune system receives that. Generally, it goes to the lymph nodes, and then it processes that protein, recognizes that as the antigen against which the body will build its own defense, both in terms of preparing the antibodies against that, as well as preparing the B cell and the T cells to recognize that and remember that. So that's the first dose job. With the first dose, some people also get some headache, sore arm. That's just the body learning. Mm-hmm. With the second dose, that's the booster dose. Priming dose followed by the booster dose. So now the immune system is like even more ready and waiting. Aha, I know you, Spike. And it quickly goes into alert mode. And it releases the cytokines, the cell inflammation signals that cause the fatigue, the body ache, low-grade fever, headache, that kind of symptom, almost like a mild case of flu. Some people notice nausea. About 10 to 15% of patients who receive the second dose of vaccine may notice slightly enlarged lymph nodes in the armpit or upper neck area. Generally, they subside. But yes, those symptoms are a little bit more obvious, noticeable after the second dose. This was seen even during the clinical phase 3 trial. In majority of the cases, these are self-limited in 24 to 48 hours max. Many people may not even need to really take many medications. If you have to, you could certainly take Tylenol to take the edge off, but use other non-pharmaceutical ways to making sure that you're comfortable, making sure you're well hydrated. If you're able to rest, that's always a good idea. If you're not feeling 100% energy, and see if you can, if you have the luxury of timing your second dose when you have a day off the following day, that makes it even, much more efficient, so that you don't have to call out or some such unexpected time off. So those are some simple tips. Yes, taking Motrin type medicine before going for the vaccine may reduce the reactogenicity, where the immune response, you need a little bit of inflammation to mount that response. So could you blunt the immune system's improvement and readiness by taking medication? Yes, it is possible, but not to a huge degree. So if you have to take medicine, of course you can take it, but generally I'm a minimalist when it comes to medicine. I'm in the wrong field, but certainly, I took Tylenol 1 dose after my second dose, and did not have to do anything else. So yes, second dose will be more noticeable. Yes, for sure.
Can I ask a question? Is one vaccine have more effects than the other, like Moderna versus Pfizer?
Yeah, both are mRNA vaccines, and typically the second dose symptom phenomenon is, I would say, pretty much similar, except for the anaphylaxis rate. The anaphylaxis, which is the severest form of allergy, where the throat can swell up, lips can swell up, blood pressure can drop, a person can go into a rash and a shock state. That's called anaphylaxis, severe allergic reaction. The latest studies have shown that Moderna vaccine results in anaphylaxis in only 2.5 cases per million vaccine doses given. 2.5 per million. Whereas Pfizer seems to have somewhere between 5 to 6 anaphylaxis per million doses delivered. So there's that mild difference there. But apart from that, I think the symptoms are pretty much identical because the immune response is similar as well. Having said that, not everyone will get all the symptoms either. One of my family member, who happens to be in their 70s, also in healthcare, received their second dose and had virtually no side effect except for mild sore arm in the injection site. And I looked like I had the man flu for 24 hours. So it's certainly individualized based on our immune system. So if you don't have symptom, doesn't mean that the vaccine is not working either. But if you do have symptom, count your blessings as long as you're healthy and say, you know what, the immune system is doing what it's supposed to do.
Thank
I
you.
have a question sort of around that same subject matter. There are a few folks that are a little confused about getting the vaccine if they are currently prescribed a EpiPen, because when you do register, at least on the MyChart app, one of the questions is, have you been prescribed an EpiPen, or do you use an EpiPen? And there's some confusion as to why that question is asked. Could you shed a little light as to folks who are prescribed an EpiPen with regards to getting the vaccine?
Certainly, and that's a great question. And it pertains to that early signal that were noticed following the launch of the Pfizer vaccine, that there were a few cases of anaphylaxis, and the presence of a pre-existing condition, either a food or a medicine allergy severe enough to require an EpiPen as a standby, certainly, it is a little bit of a higher concern, so that at least the guidance as it stands right now is that even for those people who have a pre-existing condition that require EpiPen, they may still choose to receive the vaccine, but they are recommended to bring their EpiPen with them to the vaccination site and inform the provider of their condition. The Association of Allergy and Immunologists certainly recommends that individuals who have severe allergy requiring EpiPen consult with their allergy specialist and just make sure that it is okay to take it as well. The belief is that it's one of the carrier particle called the polyethylene glycol, PEG, that may be one of the possibility what triggers the allergic reaction, not so much the mRNA itself, which is thought to be inert. But the polyethylene glycol might be one of the triggers for the allergic reaction. So if someone has pre-existing history of severe allergy to that, they just need to be more aware of it, prepare for it, discuss with their allergy specialist beforehand. And if they still choose to go get the vaccine, which is, I think, the right thing to do, because even when somebody has anaphylaxis, it is in majority of the cases easily treatable with EpiPen, Benadryl, steroids, Pepcid, the combo. None of them generally die. It is severe, so we always worry about it. But the risk of catching COVID and resulting infection and death is higher as compared to risk of anaphylaxis to someone who does not have prior history of anaphylaxis. For someone who has history of anaphylaxis, they know what to expect and they will go in battle ready and prepared. Great question.
Okay, I have another question that got brought up. Sorry about that. The second shot that I think the Moderna is 28 days. I can't remember what the Pfizer is, but if they can't get in for an appointment, or if you can explain to them, if you can't get in for an appointment, or if you have to cancel your appointment, how long can you go past that date where it's still the second shot is still being effective?
Great. So we know that Pfizer doses have to be at least 21 days apart. And we also know that the package insert for the Moderna vaccine calls for at least 28 days between the two doses. Having said that, due to a variety of different factors, number one, the scheduling flexibility. Number two, life gets in the way sometimes due to extremely unavoidable circumstances. Number three, vaccine supply may be fluctuating. So because of these real world challenges, CDC and the manufacturers of the vaccine looked at the scientific data and said, all right, here's the deal. Try to stick to the exact schedule as much as possible. But if you cannot, meaning either that, there was a massive snowstorm and that clinic had to be rescheduled, or that, something really unavoidable happened and the person who is supposed to show up for the second dose just cannot make it, not for any frivolous reason, but for real reason, they do have the opportunity to complete the second dose anywhere from 4 to 8 weeks. So it gives us a little bit more wiggle room. Even if it goes beyond 8 weeks, the guidelines say you don't have to start fresh with series of 1 followed by second. So yes, there is a little bit more flexibility, but the guidance is for everyone to try and stick to the published regular schedule.
Thank you for that. that was my questions that I had just from the past couple days. The floor is open, so if anybody would like to ask Dr. Vora some additional questions, please don't hesitate.
I have a question. This is Deb Tavernier. With all of the news on talking about the new strains of viruses coming through and that sort of thing, how effective will this vaccination be going forward when we're all dealing with these rampant strains that are breaking off and becoming stronger?
Thank you for that question, Deb. Viruses have been around, as you know, longer than humans have. And even on our own body, there are more number of microbes, including viruses, bacteria, and fungal cells than our actual human body cells. So even right now, what you see is more of a composite, a chimera of microbes, including viruses, on and inside of me, plus human cells. And the two are existing in harmony, and they actually have an evolutionary benefit and role as well. So not all organisms are evil, so let's start with that. Viruses have a normal way of evolving as well, and that's called mutation, where there is a change in their one or two locations of the RNA segment. It's called a nucleotide, and that can change the behavior of the virus due to various different reasons, depending on which receptor it changes, or sometimes it makes the virus more kinder. Other times it makes the virus more sticky and able to jump from one person to another. And we are seeing the same type of evolutionary pressure on this coronavirus, and it is showing what it can do. It is mutating as well. And when we see those mutations, they are known as variants. And we generally try not to label them, for convenience, we end up doing so, but generally we try not to label them as the UK variant or the South African variant or the Brazilian variant. It's only because they were able to do those sophisticated genome sequencing tests that they were able to find them over there. It is very much possible that the same variants were in circulation elsewhere, but we never looked. But having said that, so far the indications are, based on the research done by both the National Institute of Health and Moderna, that the current vaccine, the mRNA vaccine, is still effective against these emerging variants. There is a slight decrease in the neutralizing antibody levels against the South African variant. But what's happening is this sophisticated mRNA vaccine is so good at generating a high level of antibodies that even a decrease in antibody level in response to the variant is far above what is needed to remove the threat of the virus causing a severe disease. So the long-winded answer is that right now we are concerned about the variants, and that's why it is even more relevant for us to continue our non-pharmaceutical healthy, safe behaviors that we are so used to. We are tired of it, but we still do it. But at the same time, we know that the current Pfizer and Moderna vaccines are still going to provide adequate protection against severe disease that result in hospitalization or death against these variants. Here's the good news. Let's say the South Africa variant, the B1.153 or whatever the number is supposed to represent the variant. If that becomes the dominant strain circulating throughout America, And we find that the first variant of the vaccine was not perfect for the next new strain. The subsequent batches of the mRNA vaccine can be modified on the go as well. So yes, evolution is almost an arms race, and we have coexisted with viruses for a long time. This is a novel pathogen that our immune system has not seen before, and we know it causes disproportionate death and diseases. It is not the regular flu. For those of you who still may encounter folks who believe that this is nothing but another common cold, I can assure you that it is not. It is certainly a deadly new virus. And for those of you who may have either family or friends who are still unsure whether to receive the vaccine when the vaccine becomes available, they're still on the fence. That's okay. We don't want to shame them or make them feel different. But certainly we can share with them this clear choice. All of us who are still on the fence have to meet either the virus or meet the vaccine. We know the clear and present danger of what the virus can do, including the symptoms, which can be severe, including the hospitalization risk, the death risk. And we also know of the long COVID, the prolonged presence of symptoms, sometimes even neurological symptoms such as cognitive changes following COVID recovery. So we already know the known risk with the actual virus. We know the known risk with the vaccine, a very tiny risk of anaphylaxis, a small risk of other fever like mild flu-like symptoms, but really that's it. We also know that if someone recovers from the actual infection, they do develop immunity. The studies seem to indicate that the immunity may last for 2 years or longer, perhaps. When I was in my fellowship training in New York City, this is back in 2002 to 2005, that was a time when we had the first SARS pandemic. If you recall, many of you might remember that. It started out near Guangdong province, Hong Kong area, and then spread worldwide. Canada took a big hit. The reason I bring it up is that I was involved in the vaccine research during my fellowship for that. And we used the same exact spike gene and inserted the gene, it's called transfection, into a very benign adenovirus as a vehicle to deliver that spike into the body. And the reason it is relevant is that looking back at that first SARS pandemic, we know that the protective immunity seems to be lasting decades for this specific SARS. So we don't know that if that's the case with the SARS coronavirus 2, which is what causes COVID. But if they are part of the same sarbecovirus family, our hope is that we may see longer duration of immunity as well, especially with the mRNA vaccine. So I'm optimistic for that. But even if we have to adapt and change the vaccine mRNA sequence because the variant has changed, the technology allows for doing so on the fly.
Dr. Vora, I have a follow-up question from that part of the discussion. If they need to change the technology a little bit based on it maybe mutating a little bit, then would just the people that haven't taken the vaccine at all, would it be for the people that eventually decided to take it? And then second question, for those who have taken the vaccine, the 2 doses, do you know what kind of plans they have to evaluate whether this is something that we need to get like a booster, like a Tdap booster or a MMR booster? Are we gonna draw titers? Do we even know what the titers would be if to say you're immune or, yeah.
All great questions. And, you know, we are now in the mass vaccination phase. And I'm hoping most of the folks who will receive the vaccine will do public health service and sign up also for the vSafe system. vSafe is Vaccine Safety Monitoring System, which collects symptom profile, any adverse reaction on a massive scale, and then leverage the data science to look for signals from the noise, right? To how do you figure out if the Bell's palsy that somebody reported could just be by chance, or, you know, actually this could be associated with a vaccine. And that is only possible by looking at the big set of data. So my first request is to promote, encourage participation in this public health vSafe initiative. That's the first requirement. Because with that, we would know the safety profile on an ongoing basis. We would also know if somebody has a reinfection. So far, the reinfection seems to be very rare. So that's reassuring. But if we were to really be able to look at a broad population, we would have to be doing much more testing and genomic sequencing as well of the virus, so that we know what's the dominant strain around us. And then only time will allow us to have a more broader epidemiological awareness around the duration of immunity, whether there's a need for a booster, like you said. Now, we know that, you know, after 12, 18 months, the neutralizing antibody levels may start waning down. But having said that, it doesn't mean that our immune system has forgotten how to deal with this novel virus. Essentially, that is how immunity works. Initially, you have the antibody response, but the B cell and the T cells still learn the lessons from that initial encounter with either the virus or the vaccine. And they have the plan mapped out, ready to go if there is a second contact with the same enemy. And so even if the antibody titers are absent, it doesn't mean that we do not have immunity. Here's the thing, the neutralizing antibody may not even be noticeable, because the antibody that our body creates in response to the virus is against the spike itself. So I'm not sure how useful antibody titer levels will be, like we do with measles, mumps, rubella. In the future, will there be tests looking for the B and T cell memory readiness? I'm sure there is something in the works already, if it's not ready to be published. But yes, more to come on that. But right now, we don't know for sure if this will be an annual influenza-like vaccine requirement, or maybe, like you said, more of a Tdap booster type requirement. I'm hoping for the second.
Thanks. It's fascinating. Thank you.
I have a question. Dr. Vora, if you've already had the COVID, do you still suggest them taking the vaccine on the pretense that they would be immune?
So again, that's a very good question. If someone has already had COVID and they recovered from it, certainly they have protective immunity. The rationale behind why the Centers for Disease Control is suggesting those individuals to still consider getting the vaccine is that the scientific belief is that the vaccine-induced immune response is more robust, and the duration of that is longer than the natural immunity. That's why they're recommending even those individuals who did recover from COVID to consider getting the vaccine.
Yeah, that's a great question, Kathy. A couple more questions. I know that because of the double strain or different strains that are coming out, one of the questions is some people are wondering, is there going to be any type of, obviously we're still going to social distance and wear a mask, but some people are saying that double masks are going to be required, that is going to be different types of, you know, is that just people talking, or is that something that people should be looking out for?
If you are still waiting for the vaccine,
Mm-hmm.
and if we have indication that the more contagious variants such as B.1.1.7 and others are in our community, it doesn't hurt to have a surgical mask with an additional cloth mask on top. When you look at the works published by Dr. Monica Gandhi and others who are experts in the transmission biology of the virus, they have tried to, make a hierarchy of, what's the best protective mask versus the worst. Certainly, if everyone had access to an N95 mask, that would make much more sense. For some reason, one of the best, brightest nation in the world, we could not somehow manage to have millions and billions of masks available. I think, I hope I'm wrong, but when we look back, when the historians look back at the COVID pandemic and the national response to it, a few things, of course, will stand out. One of them is that the messaging from the beginning, minimizing the value of mask, which was, the intention was, if public starts using masks, surgical masks and stuff, there will not be any left for the healthcare provider who need it the most. So that was the correct rationale thinking. But what happened was, instead of saying, yes, everybody should wear a mask, but our healthcare folks need it the most, you can do surgical mask later when it's available. The messaging was not perfect. Let's face it. And there was a lost opportunity at the beginning. Subsequently, we did not really ramp up production on a war-like footing to manufacture surgical 3-ply mask and N95 mask. It should be available just like we do with Purell. That should be the cost of doing business. If somebody walks in without having a high-level protective mask, we should be able to give out masks for free. We did not get there. So what would I do if I did not receive the vaccine, and if I know that the South African variant, the UK variant are rampant in my area? I would recommend, if I have to go out in public, especially indoors, outdoors is still much better, safer. But if I have to be indoors for whatever reason, and I'm not able to maintain distance and it's a poorly ventilated area, I would much rather have an N95, or definitely just a surgical mask, which is available now in grocery stores as well, plus a cloth mask on top of it.
Thank you. Does anybody else? I have one more question, but I'd like to open up the floor to anybody else that might have a question.
I do have one more question, but I've already asked one. So if you have a question from somebody else, you can go first, Angie.
No, go ahead, Bradford.
Quick question. Oh,
Beth Ann, did you have a question?
did. I just was curious, is there any update as to a vaccine for children? Because I had heard, I don't know if this is correct, but like 16 and under should not receive the vaccine at this point.
Yes, Beth Ann. So the Pfizer mRNA vaccine is approved right now. The package insert calls for 16 and over, and the Moderna vaccine is approved for 18 and over. As we speak right now, the pediatric age group vaccine safety and efficacy trials are ongoing. And the hope is that by summer we'll have a much more definitive guidance based on data around the safety and efficacy of vaccines for kids who are under 16.
I have a question. Why are children not as susceptible to get COVID? What's different with their bodies?
So whether they get the infection to the same rate as adults and seniors do, I think perhaps the answer is yes. If they are in a close environment, indoor, close proximity, less masking going on, then it is likely that they receive the same level of infection, but their immune system is able to handle this COVID virus and process it so that it is able to recover faster, so that there is less overactive immune response as well. There is a phenomenon called immune senescence, meaning as we all age, our immune system changes. And sometimes it is not just our protective immune response to the virus, but sometimes it is the overly aggressive immune response to the virus, that hyperactive response that drives the damage to our own systems. So certainly, age is a major variable. We know that. We see that in our mortality rates as well. Older folks, immune system has changed where they're not able to handle the virus attack, followed by how their own immune system responds to the virus response. So yes, age does matter, and the kids are able to handle and process this virus a little bit better.
I have one more question. Is there anything we can do to boost our immune system until we can get vaccinated in case we get COVID? Anything we can do with food or medicine?
Yes. That's a great question. And I think that is true even for many other infections. I'm not sure how many of you have noticed this, but if your profession ever called for overnight shifts work, like in my line of work, in my role as a critical care physician, I used to be on call a lot, and the nights where you end up staying up a lot awake in the intensive care unit, the following day you are dragging. And if you speak with the nurses who work nights, or if they are pulling all-nighter for school and college studies, lack of sleep reduces the immune system response. So if you had to do one thing, is to make sure that you get 7 to 8 hours of good sleep at night. It improves immune response. Second thing is to get enough sunlight, vitamin D. That certainly has been shown to improve immune boost as well. Fresh green leafy vegetables and different colored fruits and vegetables, those are the nutritional immunology boost that is significant as well. So doing just one may not be adequate, but when you combine these natural immune boosting steps, then the sum effect is that you are less susceptible to catching a cold. We all know that. When we are run down, that's when we get the cold. So anything that you can do to kind of keep your batteries recharged with healthy sleep, good nutrition, and avoiding smoking. All those simple steps improve immune system.
So my other question, we had touched on this a little bit earlier, just kind of bringing the conversation back to the vaccine real quick. There are going to be people that are anti-vaxxers, and we're never going to change their mind. There's just, don't even put your energy there. They've already made their mind up. And, you know, I believe in respecting everybody's, you know, ideologies, even if I disagree with them. But for the people that are on the fence, that really have no sway one way or another, perhaps they're just seeking some information that could confirm questions they have. Are there resources out there that can provide some of these questions or answers to questions they may have? And also, are there resources out there that have been published that could help to debunk some of the myths or the noise? I mean, you hear things like, you know, the gentleman that passed away after his second dose, and he was a medical worker. And his own family said he believes so strongly in getting vaccinated, and even his family says he would still want you to get vaccinated, even though this happened, because it is such a rarity. You know, like you said, probably that 2.5 in a million. And but those stories, because they're so shocking and salacious, they make the news and they're loud, and so they sort of drown out all of the positives. So where can we point people so that they can have a healthy dose of positive information too?
Thanks for that question, Bradford. You know, certainly one of the stronger motivation for folks who are vaccine curious but vaccine hesitant, they're not outright vaccine refusers, like you said. They might be in the wait and see type phase. They want to just make sure that it is actually safe. What they've found, what the you know, behavioral health economics type folks who do this all the day long, what they found is that using peer influencers is powerful. Instead of it coming from Dr. Fauci and him alone, it is more socially powerful for the folks to see people like me that I know in my own trusted circle demonstrate that social signal. And I think that's why, you know, the vaccines, you know, the selfie with the vaccine shot, vaccines are a powerful way of promoting social awareness signals so that, you know, it becomes normalized. That's the social norm that a civilized society would hopefully expect. We are not at the point where we are mandating vaccine. It is under emergency use authorization. So I don't think we'll be mandating it, but I think it's just a matter of time before non-governmental organizations will start requiring some form of immunity check. Certainly there is discussion for international travel that you almost have to show either, you know, a positive antibody test, meaning, or a prior PCR positive for infection, at least 2 weeks or more. This way, you know that you're either vaccinated or you have survived the virus to be allowed to even travel to certain destinations. So you could imagine large public venues might start requiring something like that as a condition of participation. Perhaps sports teams might do something along those lines. Nobody blinks when you have to show your yellow fever card if you ever have to travel to Africa. Similarly, immunity passport for COVID might become the norm. And I think that'll also drive some behavior for those who are not ready yet, but they have a compelling business or social reason to, you know what, I'm gonna take it. But I would say, you know, to point them to resources that are both local, such as excellent resources provided by, organizations such as UCFS, of course, Hartford Healthcare, Yale New Haven. There are local voices built into those recommendations that all reference back to the CDC anyway. So our central location that we kind of look to are national guidelines, either from the Infectious Disease Society of America, Centers for Disease Control, certainly other ACIP type organizations. But
I have a question.
The more local voices we include, the better it is.
I have a question.
Yes.
Yes, this is France, and I had a question earlier, and it goes along with what Bradford just mentioned. Is for somebody who's curious about knowing whether the vaccination will be efficient or not, because so far they've been telling us on the news, and we all know that the vaccine of Pfizer and Moderna, which is the best so far all over the world, is being effective at 95%. So maybe that's why many people are hesitant to go and take a vaccination. Do you know whether they're currently working on trying to improve the vaccine so that everybody will be feeling safer and with no hesitation will go and do the vaccine because they want to hear something like this vaccination is finally, they came to a point in which is 99%, 100%, not 100%, but to the best. And don't you think that this will help many people to feel safer? Because I know what you mean when you say that you're going to need to have a vaccination to go to travel, because they used to do this in Africa. They used to do, now they don't do it anymore because they notice certain vaccinations are no longer good. And therefore they change, but they continue doing it from time to time. So they will certainly impose for the COVID-19. But do you know whether they're currently working on improving the vaccine?
Thank you, Franz, for asking that very important question. I think overall, we have undersold the effectiveness of these mRNA vaccine. And why do I say that? Because I think we all then start fixating on, oh, it's 94 or 95, not realizing that this level of protection is unprecedented. The story and the narrative would be perhaps a little bit better if we were to share with the whole population, the community, is that amongst the people who received the vaccine, only, one had severe disease as compared to hundreds that had severe disease without the vaccine. The vaccines are 99% effective in preventing severe disease requiring hospitalization and death, which is the real, endpoint to aim for anyway. So I think, again, from a health communication perspective, we could have done a better job at promoting the effectiveness and putting it into context as compared to other vaccines that we have no issues taking. Shingles vaccine or pneumonia vaccine, none of those are 100%. Right? So I think sometimes the value gets lost in the message and how it is delivered for a very important topic like this.
Well, but the problem is, I don't know if there is exaggeration, because I like to follow the news.
Yes.
Whether in the US or the different country in Europe, in Africa, especially in Europe. and they've been having some extreme reaction to the vaccine, such as I heard some people pass away right after getting this. I don't know what was the reason for. So when you're hearing those kind of news, and also the fact that they're telling us here in the US that after taking the vaccination, you're not going to be immediately completely protected because you will have to continue wearing the mask and practice social distancing. So how many years are we going to go on this way to say because of in spite of the vaccine, we need to continue this? So how long is going to take us to continue living this way? Because vaccination was supposed to be the answer to the problem, and so that everybody get back to normal. And now they're telling us, no, you need to continue. So that, no wonder people are wondering, is it really the best solution to get the vaccination?
Great point. And I think, France, the issue at hand is we are not safe until everyone is safe. And if we have a vaccination for 80% of the entire population around us, then certainly, you know, it becomes more of a real herd immunity. The downside is that right now we have only vaccinated less than 10% of the population in Connecticut. And even if the risk of the infection is very low and the risk of severe infection or death is extremely low after complete 2 doses of series of vaccine, 1 month out when the body's immune response is at the highest level. From a messaging perspective, I think the public health authorities are struggling because if they say, okay, if you received the vaccine, you don't need to worry about the mask, go about life like you did before. But then we don't know if folks who are walking around without the mask are vaccinated or not. We're not asking people to wear a badge indicating whether they are vaccinated and safe, and hence they can go about without the mask. So I think there's a challenge from an implementation perspective that is perhaps driving this recommendation to maintain the safety measures even after vaccination. It's not easy, you're right.
Okay, thank you.
So we've actually gone over, so I apologize for that, Dr. Vora. Is there, if anybody has any additional questions, go ahead and email me and I'll make sure that Dr. Vora gets these questions, if that's okay.
Absolutely, I'm more than happy to do another session, you know, at some other time.
Yeah, I think, well, it's obvious that there's a lot of questions out there. There's a couple more out there. So every Friday, we are going to have a lunch and learn for our healthcare committee at from 12 to 1 o'clock. And then on Tuesdays is a marketing lunch and learn as well. So yeah, I'd love to be able to follow up because I guess in a couple more weeks, we're going to have even more questions. So thank you so much for your time. Thank you everybody for joining. This was recorded, so if you need to send it or if you'd like to share it at all, I'll make sure the recording gets out there as a YouTube video and then everybody can share it as well. And again, Dr. Vora, is that safe to say they just send me the questions and then I'll send them to you? Okay, so I'm going to go ahead and put my email into the chat, and of course you can contact the chamber 860-887-1647 as well. On that note then,
take care.
All right, everybody have a great day and a great weekend.
Bye-bye.
Thank you.
Thank you.